We have male, 84 years old patient. Patient was sent to do HRCT because of suspicion of tumor on the right lung. What we can see here in this X-ray that we have the lenticular-shaped homogeneous opacity along the course of the minor fissure, which can lead us to the diagnosis of pseudotumor of pleura, due to accumulation of pleural effusion extending into the minor fissure. Here as well, there is effusion obliterating a left costophrenic angle. Here, we can appreciate presence of the pleural effusion, homogeneous opacity with well-defined interface with the lung seen along the costal margin. Here as well, we can expect presence of pleural effusion within the major fissure. The lateral X-ray will solve this issue, but showing the expansion of the fissures, minor and major, with pleural effusion. Patient underwent HRCT. Here, incidentally noted right apex pulmonary nodule with central calcification. Here we start to see the major fissures, pleural effusion, and the minor fissure pleural effusion in the lung bases. We can see here the smooth interlobular septal thickening, the hallmark of diagnosing interstitial pulmonary edema. As you can see here, it's outlining the secondary pulmonary lobules, nicely seen all over the lung bases. Here, we can see the fissures nicely extended with pleural effusion, minor and major fissure in the right lung, and here in the left lung. No evidence of masses. Presence of fluid within the fissures, extension of fluid, pleural effusion into minor and major fissures is almost always because of renal insufficiency, cirrhosis, and most likely cardiomegaly, congestive heart failure. Here we can see again the heart, the left atrium enlarged, right atrium enlarged, left ventricle, we have multiple chamber enlargement, cardiac chamber enlargement. We have atherosclerotic changes of the coronaries. Our role here is to shift the thinking of pulmonologists away from tumor or interstitial lung disease and mention that the case, frankly, is interstitial pulmonary edema due to presence of interlobular septal thickening and transudate effusion, likely because there is extension into the fissures. This patient, when he is treated properly as congestive heart failure, the findings are subsided in the chest X-ray. As you can see here now, the minor fissure regained its normal hairline opacity seen transversely in the right lung zone and almost resolved and absorbed pleural effusion elsewhere. Thanks for your attention.